is Ian Bockert.
And Liang Wu.
And welcome to the Clinical Correlation. Today's case is...
This is a 5-year-old male with no significant past medical history who presented with 6 days of cramping abdominal pain. Parents also report decreased PO intake and vomiting for the past day.
On review of systems, the child complained of aching and pain in both legs. There was also swelling and a rash on both legs described as red spots by his mother. His stools were also streaked with blood.
The mother even described his stools as a jelly consistency.
Here are his vitals. Nothing too remarkable about his vital signs except for mild hypertension.
On physical exam, he had a diffuse tenderness in the right upper and lower quadrants. His legs had a characteristic rash as seen here. Note the petechiae.
If he were to give us a stool sample, it would likely look like this. Pretty gross. The sample would also be guaiac positive.
Due to his intractable abdominal pain, a workup including blood work, UA, and ultrasound were performed. The labs and urine were unremarkable.
Though this is not our patient's ultrasound, the images were similar. So what exactly do we see?
The image on the right shows a characteristic target sign and is indicative of intussusception.
In intussusception, the bowel telescopes into itself. In longitudinal view, you can see the layers of the bowel telescoping, and in transverse, the target sign can be seen.
Treatment for this when seen is an air contrast enema to reduce the telescoping. If reduction is incomplete, a surgical consult may be needed.
As you might have guessed, this patient has Henoch-Schonlein purpura, or HSP for short, also known as anaphylactoid purpura or purpura rheumatica.
HSP is an IgA vasculitis of the small vessels. It is also the most common vasculitis of childhood.
Almost always, HSP is preceded by a URI. 95% have complete recovery after 3 to 4 weeks.
Medicine loves its triads, and HSP is no different. It has the classic triad of non-thrombocytopenic palpable purpura, abdominal pain, and arthritis.
The rash usually starts as erythematous, macular, or urticarial wheals and then progresses to ecchymosis, petechia, and palpable purpura. It appears in crops, is symmetrically distributed, and located in the gravity pressure dependent areas like the lower extremities and buttocks.
The abdominal pain is colicky and crampy, and there is sometimes blood in the stools. Only 5% of cases are associated with intussusception.
The arthritis is migratory and is usually in the knees and ankles.
The feared complication is renal insufficiency, which occurs in about 1% of patients.
The diagnosis of HSP is usually clinical. However, labs can be obtained to rule out other badness. CBC, chemistry, and coags will all be normal.
The UA will show hematuria and proteinuria due to the IgA deposition in the glomerulus. Stool guaiac will be positive in about 50% of the cases.
Treatment is supportive, usually with NSAIDs for pain control. Be aware that these can worsen renal disease if present. Only give steroids if the patient is having severe arthralgias or abdominal pain.
Most patients can go home. However, some may need admission if they have intractable pain or intussusception. Also keep in mind that the recurrence rate is up to 33%.
Our patient received a semi-emergent air contrast enema as soon as he was admitted. He continued to have abdominal pain after the reduction. However, repeat ultrasound showed no intussusception. It was decided to begin steroids due to the continued pain. He ultimately went home on day 3 with NSAIDs.
What purpura lecture is complete without a discussion of pediatric rashes?
This is probably one of my least favorite parts of emergency medicine. Because I dislike rashes so much, I tend to take a minimalistic approach. I think Sean Fox's approach, as described on his Peds EM Morsels website, is perfect.
Step 1 is to determine whether the patient is sick or not sick. If they're sick, don't waste time pontificating the rash, and do what you do as an EM physician, save a life.
If they are not sick, move on to step 2, which is to look for evidence of badness.
Does the patient have petechiae signifying ITP or meningococemia?
Is it purpura with HSP, DIC, TTP, or non-accidental trauma?
Do they have vesicles of HSV or potentially chickenpox?
Do they have bulla concerning for burns or bullous impetigo?
How about the target lesion signifying erythema multiforme or SJS?
What about severe urticarial lesions concerning for anaphylaxis?
Any desquamation that could be seen in staph scalded skin or Kawasaki's disease?
If there's no evidence of badness, move on to step 3, which is to look at the mucous membranes, because I know you didn't do it the first time. Look for anything that would help you decide what the rash is, including things like Koplik spots or herpangina.
Nothing to help your diagnosis in the mouth? Move on to step 4, which is to look for the common pediatric rashes. Molluscum, pityriasis rosea, impetigo, atopic dermatitis, hand, foot, and mouth disease, or scabies.
If step 4 still doesn't nail a diagnosis, don't admit defeat, but also don't be afraid to say, I don't know. Discuss with the parents that you don't want to label the rash wrong, and also discuss your lack of concerning findings.
Let the parents know that rashes evolve, and that close follow-up is necessary. To summarize, think of the triad of HSP: palpable purpura, abdominal pain, and arthritis.
When suspicious of intussusception, confirm with ultrasound and look for the characteristic target sign and evidence of telescoping.
Think of the kidneys. Though renal insufficiency is only seen in 1% of patients with HSP, it is an important complication to keep in mind.
And remember the 5 steps of identifying rashes. Determine sick or not sick, look for badness, look at the mucous membranes, think of the most common causes, and don't be afraid to say, I don't know.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
Thanks for listening.